important that I'd like to just touch upon for ethnic skin are the ND-YAG laser, the erbium YAG laser, fractionated lasers, and pigment lasers. These are called, these are the tattoo removal lasers, Q-switch lasers and the picosecond lasers. So for vascular treatment, I don't know if you can see that. It's not really showing up on the screen very well, but if you have a scar, a hypertrophic scar or a keloidal scar, often if you can reduce that vasculature by using a KTP laser or a pulse dye laser and then an ND-YAG laser, which is deeper on top of that, you can close those blood vessels. It might take a few treatments to do that. When the vessels are closed, not only will the lesion appear less red, but also it'll be less thick. And we would couple that with other things as well. This is using vascular ND-YAG laser for port wine stain. So port wine stains are birthmarks, they're dilatation of blood vessels that are within the skin. And you can see that this patient has had 5 sessions of an ND-YAG laser and has been quite a significant improvement. Now the challenge with laser hair removal is that not only is there pigment within the hair, but there's also pigment within the epidermis. How can we reach the hair follicle but leave the epidermis relatively intact? One of the answers is cooling, but the other trick would be to manipulate our parameters accordingly. So we need to choose a wavelength that's very specific for pigment, but not too specific. That's why I prefer an ND-YAG laser. We want to use a low fluence. We want to use a pulse duration that's very long. And if you do those things, you can hopefully just heat up the hair follicle, but not the epidermis to the point that it's damaged. This is great for, I'm sure we're going to be discussing pseudofolliculitis barbae. We treat that quite a bit using our ND-YAG laser. Here's another example of that. So in addition to reducing the inflammation caused by the hair follicles, we can reduce the hair follicles themselves. Laser hair removal on any part of the body, as long as the hairs are dark and the skin is less dark. But even if the skin is very dark, if you utilize those tricks, you can probably get to it. So other targets for the ND-YAG laser, I'll just show you very briefly. Hemoglobin absorption does occur. We saw that with the curve. There is a slight elevation, slight peak with the curve at 1064 nanometers. If we have a short pulse duration, we could probably reach the upper vascular plexus, and we can actually absorb some of those capillaries that are there. Post-inflammatory hyperpigmentation can be reached with the ND-YAG laser. We have to have a short pulse duration, and we need to have a low fluence to do that. But you could also stimulate collagen by going a bit deeper. So here's an example. So this patient, using the Visia, which is a photoanalysis system, has demonstrated a lot of enlarged pores. By using a microsecond pulsed ND-YAG laser, we can actually deposit heat to the dermis, the papillary dermis, causing that we can actually cause those pores to close somewhat. Not completely close, but at least reduce their caliber. The patient doesn't have as many pores and doesn't appear as red. Here's an example of Varicella scarring. So this is treated using a microsecond pulse ND-YAG laser. Again, we talked about the pigment, that's post-inflammatory pigmentation. That will be ruptured, or it will come up to the surface, and we can also see that the scars themselves have decreased because of neocollagenesis. Here's an example of acne scarring. This is also using an ND-YAG laser in dark skin types. So it's very important, if you have these 3 components where you have powerful micropulses, if you have high repetition and you have a large spot size, then you don't really focus all of that energy in one spot. You diffuse it throughout the papillary dermis. That causes heating, and ultimately you'll have the neocollagenesis that you desire. So if you have somebody who has red acne scars, as well as maybe even a little bit of active acne, in addition to the medications that we use, there is also light ways that we can help to reduce some of that oil production. Just another example. Now, for removing epidermal pigment, we can either use a Q-switch laser. I'm not going to go into too much detail, but we also have intense pulse light systems as well, and they both operate different mechanisms. So here's an example of dermal melanosis. This is a nevus of Oda, and this patient was born with this melan. We also call it a cellular derma because it looks bluish-gray in color. In fact, the only way to really treat this would be either a Q-switch laser, or if we do something called a fractionated laser to help to diminish that pigmentation. Here's another example. We talked about intense pulse light. This graph shows temperature versus time, And you can see that, as the name implies, it's pulse light that's very, very intense, but it's not a laser light. It's a broad band of light, and this demonstrates when the light is on, when it's off, when it's on, when it's off, and it's on and off. That's how intense pulse light works. When it's on, it'll heat up the skin tissue, but when it's off, the temperature of the skin will actually go back to where it was. And it's been, depending on your pulse delay, you can make the skin hotter or cooler, but you'll notice that the temperature of the target tends to increase quite substantially, hopefully to the point that it's impaired or destroyed. So indications of intense pulse light include all of these. Just show you some examples. Even with darker skin types, as long as we cool the skin and we make sure that we have long pulse durations, we can do very well. So for diffuse erythema, it does great. For epidermal melasma, it causes exfoliation of that pigment. And typically what will happen is the pigment will darken temporarily. Usually it takes about 2 or 3 days. The pigment does come up to the surface, and then typically will exfoliate, and we're left with less pigment than what we started off with. Another example of that. And for these early seborrheic keratoses, or these lentigos that are very stubborn, there are other ways to treat it. For example, liquid nitrogen, there's lightening creams. They also have their problems and side effects. This is one of the safer ways to do it. Lentigines off the face. This is all done by intense pulse light. Here's an example of early seborrheic keratoses that were treated by IPL as well. Now, what about combining agents? You certainly could do that. The Nd:YAG we've demonstrated is very safe for pigment depletion. Also, IPL is great for exfoliation as long as it's done in very conservative parameters. Finally, we'll leave you off with skin resurfacing. So remember, the wavelength is very important. Everything on the left side of this graph is not hot enough to vaporize tissue. It's what we call non-ablative resurfacing. And examples of that include the Nd:YAG laser, the Fractional laser. There's something called the erbium glass laser. These will heat up tissue enough that you'll have neocollagenesis, but you won't have vaporization of the surface. The ones on the right here, so the CO2 laser in particular and the erbium YAG right at the top there, these are fantastic for actually vaporizing skin tissue. Now, what is the difference? Well, practically speaking, non-ablative doesn't have any skin vaporization, so there's not a lot of downtime at all. We're talking some redness, a patient's ready to go perform school, work, functioning the next day pretty much, depending on the energy that you're using. There's a wound healing response that takes some time to fully take effect. It can take weeks to months before you fully realize the effect of that. But at the end of it, if you're lucky, you'll see neocollagenesis, which translates into skin thickening, smoothening, and tightening. Ablative lasers, on the other hand, do vaporize skin tissue. So these are what we call a wow effect. So essentially an instant smoothening of the skin, you have a tightening of the skin, as well as a thickening of the skin over time. So here's an example of one treatment of ablative resurfacing. This is 5 months after treatment. This is also confluent erbium YAG resurfacing. I prefer to use an erbium YAG because there's less collateral damage. That particular wavelength, very specific for water absorption. And then there's this concept of fractional laser resurfacing. So there's, when you talk about ablative laser resurfacing, there's confluent or full contact resurfacing, and I want to introduce this concept called fractional resurfacing, where if you had a surface such as this, go back, such as this area here, instead of treating 100% of that surface, we only treat a fraction of that surface. And typically that's anywhere from 8 to 25% of that. Once you start getting more than that, then we're talking about a full surface field. The benefit of doing this is several-fold. One is that we can actually remove skin and cause some tightening of the tissue. We can also remove some of the target and, for example, pigment that's deeper in the skin, because those columns, those microthermal zones can actually extend quite deep. So examples of treatment targets include lentigines, keratoses, scar management, scar revision, even melasma. So out of the 3 different types of ablative lasers, you can see that they look the same from far, but if you look closely, the carbon dioxide laser actually has this rim of nonspecific thermal coagulation right here. So that's actually a zone of necrotic debris, and that, unfortunately, depending on how large it is, how intense it is, can cause post-inflammatory hyperpigmentation. We see that as well with this YSGG laser, but we don't see it as much with the erbium YAG. Why? Because that particular wavelength is very specific for water absorption. When it creates that channel, there's not a lot of collateral spread. So because of that, this is our treatment of choice for fractionated ablative lasers. An example of that, so this patient is my patient. She's a zookeeper. She's out in the field a lot, outside. Quite notorious melasma. She's tried everything from peels to IPL to lightening creams. We did a single treatment of fractionated laser and had about a 50% improvement. Second treatment, it was about an 80% improvement. She continues to still receive treatments. So this is 6 months after 2 treatments. This is an example of acne scarring. So 4 weeks after 1 treatment, if you look really closely, they won't appear as indented acne scars, ice pick scars anymore. They look like small little pores, and you can do that more over time. So we talk about the wow effect with ablative lasers, and before we used to think you can never treat patients who have ethnic skin. Well, that's not true anymore. You can do that using this technology. And there's a number of different products that are available. You can also use it for pigmentation, scarring. We are now using it also post-Mohs micrographic surgery. So as soon as these sutures come out, if you go ahead and use, not necessarily an erbium YAG, we do it with a carbon dioxide laser as well. We just reduce our fluence. You can actually have a much better looking scar over time. Here's an example of combining a non-ablative laser with an ablative laser. The non-ablative laser causes collagen production deeper in the skin. There's minimal downtime. But if we add to that mix an ablative laser, we can have a wow effect in both regards. We can have smoothening, tightening, and now thickening of the skin as well. That's another example. And I think that's it. Went a little bit over, sorry. Thank you. Yeah, the question is, how would you treat Sturge-Weber syndrome? So the Port-Weinstein part of that would be treated by any one of the vascular lasers that we discussed. So typically we'll do a KTP laser for the superficial component of it, and then for the deeper component we'd use an ND-YAG laser.
How well do they do?
They actually do very, very well. The earlier you treat, the better it is. So now we've discovered that the longer it's there, those blood vessels are quite stubborn. But if you can treat it within the first few years of life, it's actually much better.
Treatment for keloids, do they respond very well to laser, or do you have to inject it with steroids?
Yeah, that's a good question. What about treating keloids? So typically what happens is if you just use lasers by themselves, if they're vascular laser, let's say it's a red keloid, you're not going to have much success because the collagen that's there is actually quite thick. And often the blood vessels are intercalating within the collagen itself. So we'd like to flatten it first. Once it's flat, then we go ahead and we treat the color component of it. So any scar, that would actually hold true. I would divide up that scar into a textural component, then a color component, treat the texture first, and then treat the color second.
You did mention something about treating water lesions with laser. Now, what do you mean?
I'm sorry, one more time?
Let's have a question over here and invite you for a corridor consultation. Last question over here.
You said for the nevus of auto, you use the Q-switch laser. Do you use the 1064 or what do you use?
That's right. So there's 3 Q-switch lasers that are available. There's the Q-switch Ruby, which is 694, Q-switch Alexandrite, which is 755, and then the ND-YAG Q-switch laser, which is 1064. You want to choose the longest wavelength. So in this case, it'd be the 1064. If we use any of the other 2, sometimes there is so much absorption and collateral damage that you can cause post-inflammatory pigmentation with that. You could use it, but I would reserve that for more lighter skin individuals. It's better to use the 1064. There's a new type of laser called a picosecond laser, which rather than fluctuating in the nanosecond is actually in the picosecond pulse duration. It's even safer if you can use that.
Thank you very much.
Thank you. Thanks, Shafin.
Okay. Thank you very much, Dr. Rao. I think we can sense that you've just touched the surface of a very deep and rich and expanding field, so I appreciate, I think we collectively do, your review of laser physics, the target tissue, cells, components, the treatment parameters, and this interesting term which is quite current in the United States, but probably has some political impact here in Canada, skin of color. the issues of photothermolysis and spot, pulse duration, penetration, and of course the nuances of the many, many choices. So I thank you once again on our collective behalf, as well as, by the way, your review of the James Bond movie, Goldfinger, which, by the way, was made in 1963. And if those of you have actually watched that scene, as I and my son have done, he had to introduce the word laser because it wasn't current amongst sort of North American vocabulary, so it's quite interesting. Our next presentation, two presentations, will be by Professor Andrew Alexis, who is chair of the Department of Dermatology at Mount Sinai, St. Luke's, and the Mount Sinai Roosevelt hospitals in New York City. He is the director of the Skin of Color Center. He's been honored and celebrated for deep contributions to the field, having 2 textbooks to his credit, including Skin of Color, a practical guide to dermatologic diagnosis and treatment, as well as Ethnic Dermatology, Principles and Practice. And I might just say perhaps a shout out to my Canadian colleagues. I think it's interesting when we interact with our U.S. colleagues because they really do seem to have established various departments and kind of often leading the field. For example, in all over the United States, there are departments of preventive cardiology, and to my knowledge, there's no such thing so far anyway, even though we may be attempting to practice that. So I think we appreciate the ability to exchange knowledge and gain some of the insights that you've had. So I now invite, live from New York, Professor Andrew Alexis.
Good morning, everyone, and thank you so much for the warm introduction. I want to thank Mitch Shannon and Dr. Scheer and all the organizers of this wonderful first-of-its-kind event here in Toronto. This event is near and dear to my heart. On a personal note, I was born right here in Toronto at Women's College and grew up in Mississauga. My father is Greek and my mom is from Ghana. So growing up the son of 2 immigrant parents here in Toronto with darker skin, this has been a passion of mine a long time. And I commend the organizers for bringing this important subject matter to Toronto. And I hope that this, I'm sure that this will be a very successful event annually. And I am excited to see it expand to other cities. So today I'm going to talk about aging concerns, aesthetic aging skin concerns in darker skin patients. And first, my disclosures, I have worked with a number of companies that are relevant to this topic, and those are shown here. Now, up until the past decade, most discussions of aesthetic concerns in dermatology were limited, largely limited to the concerns of lighter skin types, Fitzpatrick's 1, 2, and 3. And it's really only been in the past 10 years or so that we've started to discuss and study the aesthetic concerns and doing cosmetic procedures in the very broad range of non-white racial ethnic groups, Fitzpatrick skin types 4, 5, and 6. And until the development of some of the newer technologies and techniques that we have now, these patients with these sorts of skin types were actually excluded from most of the studies with laser devices or fillers and other cosmetic procedures because of safety concerns. But this has changed considerably over the past decade. Already in the United States, just under a quarter of all cosmetic procedures are being done on non-white racial ethnic groups, and this is projected to increase considerably over the next decade. This background area has already been very well reviewed by Dr. Rao, so I'm going to move quickly here. So when thinking about aesthetic concerns and skin aging concerns in darker skin, it's good to think of the underlying structural and functional differences, and we'll quickly go through this since it's already been discussed. But number one, there's increased melanin in the epidermis, and this has some important clinical implications. Number one being that there's natural protection from ultraviolet radiation from the sun, and we see this manifest clinically with delayed onset of features of photoaging and generally less severe features of photoaging. And just to illustrate, on the left is an 82-year-old woman who spent her entire life in Ghana, very close to the equator, so a lot of sun exposure, and yet she lacks a lot of the very severe textbook examples of photoaging on the right. Histologically, as one would expect, we see differences in the age of onset and severity of photoaging. On the left is a biopsy from a 50-year-old African-American woman from Southern California, and on the right is an age-matched Caucasian woman from the same region. And whereas on the right, there are all sorts of the characteristic features of photoaging with solar elastosis and degradation of the collagen and flattening of the reedy ridges, flattening of that epidermis there, and you don't see those features on the left. Melanocyte reactivity is a feature that is very important to consider when treating darker skin types. If we inflame the skin, we injure the skin in any way, whether it's with a device or a treatment or a topical, we run the risk of increased pigmentation or reduced pigmentation, hyper or hypopigmentation. Similarly, if we injure the dermis, the fibroblasts tend to be more reactive to injury and inflammation. In fact, dark-skinned individuals form keloids 15 times more frequently than those with lighter skin, according to a review of the literature. So what are the key aesthetic skin aging concerns that we see in darker skin types? Well, first are pigment alterations, and these are a broad range of pigment alterations, including melasma, solar lentigines, especially in the lighter brown skin types, especially East Asians, and just non-specific mottled pigmentation also related to photoaging. A study that was done a few years ago comparing Chinese, ethnic Chinese populations and French population, 160 age-matched women from each group were examined by a single dermatologist, and what was found was that wrinkle onset was approximately 10 years later in the Chinese cohort versus the lighter-skinned French cohort. And pigmented spots were more frequent in the Chinese population versus the French population, and this tendency increased with age. So this supports what our clinical observations in the practice. Beyond pigmentary disorders, there are benign facial neoplasms that become more frequent with age, more common with each passing decade. And some of these neoplasms you'll see more frequently in specific populations. So these are seborrheic keratoses, which can affect any part of the body, but they frequently affect the face in certain populations, including East Asians, and this is from a Korean study. In individuals of African ancestry, both men and women, smaller versions of these seborrheic keratoses called dermatosis papulosa nigra, a very, very common benign neoplasm and is a common aesthetic concern, patients coming in asking what are they and can I get them removed. Textural irregularities, and Dr. Rao did touch on this briefly, and this is an extremely common aesthetic concern in my practice, sort of these non-specific textural concerns like, doctor, my face looks dull, my pores are enlarged, my skin looks a little rough. So these non-specific textural irregularities are a frequent aesthetic concern in this population. As in any population, the features of intrinsic aging, but the nuance here is that in darker skin patients where extrinsic aging, damage from the sun, tends to be less marked, less prominent, the features of intrinsic aging, such as midfacial volume loss, can be more striking. So I find that the complaint of more prominent nasolabial folds is more frequent than wrinkles in this population and the higher Fitzpatrick type spectrum. Dynamic rhytids can certainly affect this population as it can any other, but as I said, I find that this tends to be a little less significant, delayed onset, and seems to be, while it is a major cosmetic concern, it tends to fall behind volume loss, in my experience. So what are the top rejuvenating procedures to address these various skin aging concerns? So in my practice, the top procedures would be chemical peels for the textural irregularities and the pigmentary abnormalities, removal of benign lesions, such as DPNs, dermatosis papulosa nigra, laser resurfacing with caution, botulinum toxin for dynamic rhytids, and soft tissue fillers. And we'll quickly go through each of those. Now, when thinking about performing cosmetic procedures, we always have to remind ourselves ourselves of this delicate balance between the controlled injury of the aesthetic procedure we're performing and the risk of pigment alteration and scarring depending on the degree and level of injury. So what's the worst that can happen if we're a little bit out of balance, a little too aggressive with the treatments that we use? The problem is we run the risk of inducing some pretty significant disfiguring complications, which are obviously something to avoid at all costs. So the key goal is to minimize the degree of epidermal and dermal injury and take appropriate pre- and post-treatment precautions, which might include skin lightening products, sun protection, etc. And a general theme is to consistently use conservative treatment parameters. This is not the type of patient population to be cavalier and overly aggressive because of the potential consequences. So when it comes to hyperpigmentation, the most common issue that we deal with in this population, we have various tools in our toolbox, including topical bleaching agents, and hydroquinone remains our workhorse and gold standard, but a growing list of non-hydroquinone products, which I'll talk about. And then there are in-office procedures, which we often use in conjunction with topical therapies to get more effect, including peels, lasers, microdermabrasion, microneedling. So when it comes to our various treatment options for hyperpigmentation, it's useful to consider the mechanisms of action. And what we have here is a picture of a schematic of a melanocyte, and you see the little globules, the melanosomes here, at the transfer of pigment into the keratinocyte. So we have agents that can block the rate-limiting step of pigment formation, blocking tyrosinase enzyme, and hydroquinone would be the best example of that. But there are other non-hydroquinone agents that work by this mechanism, most notably azelaic acid and kojic acid. We have agents that block the transfer of pigment from the melanocyte to the keratinocyte, and retinoids can do this, soy trypsin inhibitor can do this, and niacinamide can do this. We have procedures and agents that can remove excess epidermal melanin, and we can do that with chemical peels. That would be superficial chemical peels for safety reasons, and topical retinoids. And we can also just shut down melanocyte secretory function with topical corticosteroids. And all the while, we want to prevent UV-induced melanogenesis by encouraging sun protective behavior and using broad-spectrum sunscreens. Now, while hydroquinone, as I mentioned, remains our gold standard and our workhorse ingredient when it comes to lightening the skin, there are limitations, including irritant contact dermatitis, especially if we start compounding it to higher strengths beyond 4%. And there are concerns about long-term use, in particular the disfiguring pigmentary abnormality called exogenous ochronosis from overuse of hydroquinone. So there's an increased demand, growing interest on the part of the medical community, but especially consumers, for non-hydroquinone alternatives. And there's a growing list of cosmeceutical, non-prescription, non-hydroquinone skin lightening compounds that are that have actually undergone small but blinded controlled studies. And I find that they're useful as adjunctive treatment or for maintenance treatment, but still have not found anything that really truly replaces hydroquinone. This is one of the newer agents that is a combination of 8 different ingredients that work at various steps to reduce melanin production and produce skin lightening. And this has been shown in several studies to be efficacious in treating hyperpigmentation in darker skin types. But often topical therapies are not enough, particularly when the level of the pigment is deeper. If it's in the dermis, it is more challenging to treat. And so we often have to combine the topical therapies with in-office procedures, including non-ablative fractional laser, which we've just heard about, the 1927 nanometer thulium laser is useful for epidermal pigment and very superficial dermal pigment. The low fluence Q-switched anti-YAG is widely used, particularly in East Asia, but does have its limitations, as approximately 10% of patients in Asian studies have, it's been reported that they've developed this hypopigmented, this sort of spotty hypopigmentation. And so one has to be very careful with the fluence and the frequency and the number of passes that one uses here. Textural irregularities, including enlarged pores, roughness, loss of radiance, or just dullness, as patients might describe it. My general approach is starting with topical therapies, and topical retinoids are really the workhorse here. And for those that need additional improvement, superficial chemical peels, microdermabrasion, or for more robust and long-lasting improvement, non-ablative lasers such as the microsecond pulsed anti-YAG and fractional non-ablative laser. When it comes to actual evidence to support these treatments, unfortunately, we're dealing with very small pilot studies, and for the most part, an anecdotal experience. But this is a pilot study using salicylic acid on 25 subjects with darker skin, and 5 of this group had rough textural changes and enlarged pores, and all 5 demonstrated a greater than 75% improvement following a series of 5 salicylic acid chemical peels ranging between 20 and 30%. So this is really my most common chemical peel for this indication in my practice. When it comes to laser or light-based devices, the non-ablative fractional is very effective for producing improvements in texture, and the microsecond pulsed at 1064. Some quick examples. It's hard to reproduce in photography, but patients generally notice a smoother texture. This patient was treated for acne scarring, but also you can see the cosmetic benefit as far as just a smoother texture and a more radiant skin after 4 treatments with the non-ablative fractional. To do this safely, there are some precautions one has to take. I recommend pre- and post-treatment with hydroquinone or other bleaching agents to minimize the risk of post-treatment hyperpigmentation. But most importantly, lower treatment levels or treatment density, the density of these microthermal zones of injury that are induced by the fractional laser is very important. Microsecond pulsed anti-YAG is a very safe procedure if done appropriately in darker skin, and can produce nice textural improvements as shown here and here. And no anesthetic is required. It's a relatively quick procedure, and the risk of hyperpigmentation is extremely low, so pre- and post-prophylaxis with bleaching agents is generally not required. However, you do need multiple treatments to achieve a cosmetically meaningful result. And this is how it works. It basically works by bulk heating. You hold the handpiece about centimeter and a half away from the skin and go over it multiple times. And as you can see, the skin, in particular the dermis, heats up, and this produces neocollagenesis. The thing is, though, you're not going to see a dramatic change just after one treatment, and a lot of patients, after paying for these procedures, expect a dramatic transformation. So we do have to establish realistic expectations that we're making small incremental steps, the baby steps towards the final goal. When it comes to the removal of benign lesions, this is an extremely common concern. This is what drives a lot of patients into the office. What are these things on my face, and can I get them removed? And the answer, of course, is that these are benign, genetic. The one has a genetic predisposition to these, and yes, they can be removed, but with caution. So when thinking about removing these, you want to pick a modality that's going to, and a technique that's going to induce the least amount of collateral damage. You want to target the lesion, but minimize damage to the sublesional skin and perilesional skin. So you can use liquid nitrogen cryotherapy in this instance, but very, very cautiously. Certainly if you're too aggressive, you are going to get some hypopigmentation. So